Good morning, everyone, and welcome to this second webinar for 2025. Today is a very other intriguing topic about cervical cytology, a pattern-based approach. Our speaker is an amazing speaker, Professor Giovanni Negri from Bolzano. If you can go with the other slides, please. I would like to introduce Professor Giovanni Negri, working as mentioned in Bolzano, scientific responsibility for the cervical screening in South Tyrol, Italy. Member of the Educational Committee of the European Federation of Cytology Society and chair of the annual tutorial. Concerning the field of interest, of course, cervical and effusion cytology, molecular cytology, GYN, as well as hematopathology. It's a great pleasure and my honor to introduce him in this mostly pattern-based approach to GYN.
So thank you very much, Diana. Thank you very much for the very nice introduction, and thank you very much for inviting me to give this talk. It's of course a great honor for me. So we are going to discuss cervical cytology, and we are going to discuss mainly morphology, not only, but mainly morphology. But you're going to use a slightly different approach to cervical cytology, not with a Bethesda classification in mind, but using a pattern-based approach. So first of all, this is my disclosure. So actually, when you look at your glass slide or you look at your screen nowadays, everything is changing, and you see abnormal cells. Usually, your abnormal cells belong to one of these patterns. They may be large cells, abnormal cells, large or mid-sized to large cells, or small cells, or maybe glandular epithelia. And it's important to remember that if you use these patterns, actually for each pattern you have only a relatively small number of possible differential diagnoses. And we begin now with the large cell pattern. And as you see, you have only few differential diagnoses, actually 3. Of course, there are exceptions, but this works in most cases. So in large cell pattern, if your cells, abnormal cells are large, you have to rule out a low-grade squamous intraepithelial lesion. Of course, inflammatory changes, tissue repair. Tissue repair in some cases shows smaller cells, not so large, but we are going to discuss it here. Then, of course, cancer, large cells, and keratinizing type cancer. And if you can tell, particularly between low-grade lesions and inflammatory changes, you are going to call the changes probably ascus, and we are going to discuss that too. So beginning with a low-grade squamous intraepithelial lesion, usually the diagnosis is really simple. You see cells, large cells with abnormal nuclei, typically enlarged nuclei more than 3 times, or very hyperchromatic nuclei. In some cases, you see as much chromatin because of degenerative changes, because of pyknosis, and you can't recognize the chromatin structure. And you may have also binucleation, of course. You may have dyskeratosis. And if you are really lucky, you may also see some typical large perinuclear halo, and these are coelocytes. Coelocytes, of course, need to show a typical nuclei. Without the typicality of the nuclei, you can't call them coelocytes. So this is a quite simple diagnosis in most cases, and it's important to remember that most of these cases, about 80%, is going to regress within 2 years. Although some of these may already have follow-up of high-grade lesion in histology. So the main differential diagnosis is, of course, with reactive changes. In reactive changes, they may be associated with a specific infection, for example, Candida or Trichomonas. You usually have more diffuse changes with a relatively high number of cells with some nuclear enlargement, typically up to 2 times times compared with normal cells. You may have small nucleoli. You may even have some perinuclear halo, usually very small, narrow perinuclear halo, differently from what you see in coilocytes. And in coilocytes, in true abnormal cells, in true lesions, you usually see a dynamic in the smear. So you have some atypical cells, and then you have a background that is completely normal. And in reactive changes and reactive conditions, you usually have a quite diffuse changes without this dynamic that you have in dysplastic cells. In some cases, you may have quite large perinuclear halos, maybe because of degenerative changes, maybe because of accumulation of glycogen. But in that case, you do not have the typicality of the real locell. So one important differential diagnosis, of course, with the squamous cell cancer, particularly with keratinizing squamous cell cancer. In cancer, you may have some cells, large cells, that mimic a locell, for example, this one. But actually, you have a very polymorphous picture. You have cells, large cells, you have small cells. All these cells are really atypical with an evident atypicality also of the small cells. Different shapes, different size. You may have some tadpole cells, as in that case. And even in keratinized cancer, if you look carefully, in many cases you see at least some tumor diathesis. So no real problem in the differential diagnosis. Here are some other examples. You see large cells that mimic a locell, but a very high typicality with the tadpole cells. And here again, a very high typicality with large cells, smaller cells, elongated cells. Overall, a very typical picture. In non-keratinizing cancer, it may happen beside the tumor diathesis, which is usually very evident, that you have cells with very evident macronucleoli. And when you see macronucleoli, you should always rule out two different conditions. The one is, of course, cancer, so a very high typicality, tumor diathesis, very high polymorphy of the nuclei and the cells, and tissue repair. In tissue repair, you have sheets, bidimensional sheets of cells, which are cohesive, which are polarized, and the nuclei may be really enlarged. You may have very evident nucleoli, but you have no tumor diathesis in the background, no isolated cells. So actually, it's the differential diagnosis in most cases, it's not an issue. And actually, if you think about that, that's all. When you look at your glass slide and you see large abnormal large cells, if you see nucleoli, you have two main differential diagnoses. You see cell sheets with smooth outlines of the nuclei, polarity, no isolated cells, no tumor diathesis. It's a tissue repair. You see isolated cells with atypicality, tumor diathesis, hyperchromasia. Probably it's going to be a non-keratinizing squamous cell cancer. If you do not see nucleoli from the beginning, you are going to see, you see enlarged nuclei, hyperchromasia, coarse or granular chromatin, maybe coilocytes is a locell. If you have a higher typicality again, if you have small and large cells, if you have a tumor diathesis, think about a keratinizing squamous cell cancer. And if you have some nuclear enlargement up to 2 times, no hyperchromasia, no coilocytes, think about reactive changes. So actually a really small amount of differential diagnosis in most cases. So there are, of course, exceptions. And one of the most important exceptions is pregnancy. So in pregnancy, you may have in about 10% of pregnant women, you may find some decidual cells. They're actually stromal cells with nuclear enlargement, which may mimic a locell, or even in some cases, even when you're a little smaller, they may also mimic a high cell. But the criteria are the same. So you have enlarged nuclei, you have a often grayish, fine vacuolizated cytoplasm, which is quite typical. And most important, you may find in many nuclei small nucleoli. So the differential diagnosis is then relatively simple because you never have a nucleoli in locell. And so that's your main differential diagnosis in that case, for example, would be with tissue repair. But that's not so important because both conditions are benign. So most important is to recognize that it's not a locell. If you are not sure, a call to the gynecologist may be really helpful. And clinical data, of course, are very important in that case, and very important in the next case, cellular changes associated with radiotherapy or chemotherapy. In that case, you may have a very high atypicality, very large cells, very large cytoplasma, and then large nuclei. And in some cases of, for example, here, this is a case of bone marrow transplantation. So after conditioning therapy with busulfan, and you see you may have a real evident atypicality, but you also have a large number of bare nuclei on the background. And if you look carefully, you see that actually these nuclei have a relatively fine chromatin. That's not typical for a cancer. But of course, if you do not know the clinical data, it's maybe very difficult to distinguish a cancer from such changes. Look carefully to the background. You do not have tumor diathesis. Look carefully to the chromatin. And again, if you are not sure, and particularly if you know that the woman has a history of hematologic condition, then a call to the gynecologist could be very, very useful. If you can tell, typically between a low-cell and reactive changes, probably you're going to call your case ASCUS, atypical squamous cells of undetermined significance. So ASCUS was actually in the past a very common diagnosis because before the introduction of HPV tests and screening, most of the women who were referred to colposcopy were referred not because of straight cell, but because an ASCUS. And nowadays is maybe more simple to manage these cases anyway. ASCUS means that you have some nuclear changes, typically enlargement up to 3 times. You shouldn't have much hyperchromasia. You shouldn't have nuclear membrane changes. And but in some cases, you may still have some, for example, here some hyperchromasia. It's maybe the only one part of your slide with some changes. So we are going to prefer maybe to call it ASCUS and see what's going to happen. Actually, the management of ASCUS really depends on the setting, on your setting, whether you're working in with HPV in the context of a primary screening or not. For example, if you use conventional smears, this case probably is going to be called ASCUS. Same if you use if you have liquid-based cytology but no HPV triage. If you can do HPV triage and your HPV is negative, probably you're going to call it negative and tell the woman, see you typically in 3 years. If you have a HPV positive test, so you can call it ASCUS, you can even call it low-cell because the positive predictive value of a HPV positive ASCUS is the same as in low cell. So you could theoretically upgrade this case to low cell, anyway, referring the woman to a colposcopy. But if you get this case because the woman is HPV positive, so this is the typical setting of a primary HPV screening. And you could theoretically, since the woman is going to have anyway a follow-up in 1 year, usually in 1 year. So you could theoretically say that's not true dysplasia, so you do not need colposcopy. I see you in 1 year. All these different managements work fine, depending, of course, on your guidelines, depending where you're working. And it's going to be even more granular in the future with the introduction of extended genotyping. Because, for example, in that case, if you have a positive HPV 16, probably you're going to send anyway the woman to colposcopy and anyway this woman. But if the HPV is, for example, a less aggressive HPV, for example, 68, then probably you are telling the woman anyway, so 1 year it's going to be enough. So it's going to change and it's going to be far more granular and interesting. So the second pattern is the small cell pattern, and this includes a high-grade squamous intraepithelial lesions, high cell inflammatory changes. Metaplasia is maybe the most important differential diagnosis, then a cancer of small cell type, and if you can tell, you can call it as age. So concerning high cell, this is again usually a very simple diagnosis. You typically have hyperchromatic nuclei with abnormal nuclear cytoplasmic ratio, and what's very important, you have a very polymorphous picture with very polymorphous nuclei. And look here, these are only 6 cells, but you already recognize a very evident polymorphy. That's not normal. And if you look at this group of cells, for example, you see also a very regular membrane with grooves, indentations, and that's not possible in reactive changes or even in low cells. So that's quite typical for a high cell. The main differential diagnosis is going to be with metaplastic cells. So in metaplastic cells, you usually have the typical dense cytoplasm of metaplastic cells. You may have some vacuolization, degenerative changes, macrovacuoli, as in that case. But the nuclei are quite regular. You do not have evident hyperchromasia. You do not have evident polymorphy or nuclear membrane changes. Even if you have a little more evident reactive changes, you may see a little more polymorphy, but the nuclei, the overall polymorphy is still relatively low, and you do not have nuclear membrane changes and no real hyperchromasia. So if you look at this picture, you may see both conditions. On the left side, these are metaplastic cells with very regular nuclei, no nuclear membrane irregularities. And look at the right side, that is dysplastic. It's actually a high cell and moderate dysplasia. Look how polymorphous these nuclei are, large nuclei, smaller nuclei with grooves, with indentations. And this is dysplastic as a high cell. That's not dysplastic, metaplastic changes. So most cases, no problem. Of course, never forget that in some cases you may see high cells with metaplastic features, dense cytoplasm, as in that case, but your diagnosis is going to be done at the nuclei, which are really atypical, very regular nuclei. So again, a high cell in that case with metaplastic features. Another particular case is the so-called pale high cell. In that case, usually these are moderate dysplasia cases and with a relatively high amount of cytoplasm. And it depends, of course, on the stain that you use in your lab. If you have a relatively light stain, probably you are going to see more often these cases. If you have a darker stain, for example, if you're using artificial intelligence supported system, they often rely to relatively dark stains, then you're going to see these changes, this pale high cell less often, but you're still going to see some of this. So in that case, you see a lack of hyperchromasia, of real hyperchromasia, but look at this nuclei again, very high polymorphy, very evident nuclear membrane alterations with grooves, with indentations, again in this case, so it can only be a high cell. Another challenging differential diagnosis may be in atrophy. So in atrophy, you may have very evident degenerative changes with nuclei that are very dark because they are degenerated, and you may even have some eosinophilic cytoplasm in this case, but most important, dark, very dark nuclei. But these nuclei are smaller than usual, even for an atrophic smear, because as a consequence of pycnosis. So in real neoplastic or dysplastic changes, you actually have dark nuclei as here, but you have an enlargement of the nuclei. So the nuclear cytoplasmic ratio is very abnormal even for an atrophic smear. And besides this, you have a very high atypicality of this nuclei. So look in atrophic smears very careful at the nuclear cytoplasmic ratio and nuclear atypicality. Another differential diagnosis that is quite rare actually, is the small cell cancer. So in most cases of cancers, you may have some small cells, but you have, as we have seen, very different sizes of cells. And when you see only small cells with a lack of cytoplasm, probably it's going to be a neuroendocrine cancer. And these cancers are quite rare, make less than 1% of all gynecologic cancer. They are HPV associated. And typically they show very dark hyperchromatic nuclei unless there is an extensive necrosis, as in that case. So in that case, it happens that the nuclei are no more so hyperchromatic. You see a very scant cytoplasm. You may see nucleoli, not always, but you may see them. And usually, of course, you see a very evident tumor diathesis. So the main differential diagnosis actually in this case is with endometrium. But even if you mistake these cells for endometrial cells, they are so atypical that you are not going to call it negative. So it's already anyway fine. So if you think about that again, that's the small cell pattern. Not always, but in most cases. If you see three-dimensional clusters of cells, that's something different. It's going to be extra cervical. It's going to be endometrial cells or metastasis. We are going to discuss it later. If you see isolated cells or two-dimensional groups, and you see cohesive cell sheets with a dense cytoplasm with a smooth nuclear lines, no hyperchromasia, it's going to be a metaplasia. If you see atypicality with anisokaryosis, with hyperchromatic nuclei, with abnormal nuclear cytoplasmic ratio, with nuclear membrane changes, and you see no tumor diathesis, it's going to be high cell. If you have tumor diathesis, you have a very high atypicality. If you have a lack of cytoplasm, consider the possibility of a small cell cancer. Again, these are the main differential diagnoses. If you see small cells, your small cell pattern. Of course, it's not always so simple. In some cases, you may have some suspicious cells. For example, they cell, and maybe it's the only one cell in your sample, and there's an abnormal nucleocytoplasmic ratio, some hyperchromasia, no real membrane changes. And in that case, maybe you prefer to call it as cage. Atypical squamous cells cannot exclude a high cell. It's, of course, a lesion with a quite high lesion diagnosis with a quite high positive predictive value, about 40% for sign 2 plus. Another possibility, you have metaplastic cells with some irregular nuclei. Maybe it's the only group of cells that look so atypical. You have some irregular nuclear membrane, but no real polymorphism. And again, maybe you prefer to call it as cage, or you have hyperchromatic crowded groups that are more difficult to look at. And again, you prefer to call it as cage. So as cage is actually a borderline diagnosis. And another in borderline diagnosis, that one, look at low magnification. You see a high number of large cells with enlarged nuclei. So you think that's going to be a low cell. Large cells, large nuclei, typical nuclei. But if you look at this group of cells and you look at high magnification, you're going to see that actually these nuclei are not so round. They're actually highly typical with a regular membrane, grooves, indentation. These are not the nuclei of a low cell. These are the nuclei of a high cell. And in fact, if you look carefully, you see that some of these cells are not so large as they should be for a low cell. So as this case is going to be a high cell, a moderate dysplasia in histology. And if you are not sure whether the cells are really large or small, then look carefully at the nuclei, because these nuclei are not the nuclei of a low cell. It's going to be a high cell. So the last pattern is the glandular pattern. Again, actually only three main differential diagnoses: adenocarcinoma in situ, reactive changes, invasive adenocarcinoma, and, if you can tell, atypical glandular cells. So in glandular epithelia, it's really important that one remembers how normal endocervical cells look. And if you look at this picture, this is histological picture, and you see that endocervical cells are columnar epithelia with a lot of clear cytoplasm, very regular nuclei, round or oval nuclei, a very normal nuclear cytoplasmic ratio. And if you imagine to take some of these cells and make a cytology, you are not going to find so many isolated cells and as in squamous epithelia. You are mostly going to find sheets and groups of endocervical cells with the same features of this picture as in this picture. And maybe depending, if you look from the bottom, from the top, you may have the typical honeycombing pattern that is well known with very regular nuclei and clear sheets of cells because they have a large amount of cytoplasm. And that's one really important criteria. As of course, endocervical cells may show a lot of variations. And for example, they may have more cytoplasm, less cytoplasm, elongated nuclei, both, but they still are clear sheets with a normal nuclear cytoplasmic ratio, and that is important for our differential diagnosis. And if you look at, beginning with the adenocarcinoma in situ, look at this gland again, an histology, and on the right side you see normal endocervical epithelia, clear epithelia, very evident cytoplasm, small nuclei. And on the left side you see a partial involvement of this gland by an adenocarcinoma in situ. And if you look carefully, you see there is an evident nuclear crowding. There is a lot of nuclei. Cytoplasm is clearly decreased, and nuclei are elongated and atypical. So that's what you see in adenocarcinoma in situ. And if you take some of these cells, you are going to have the same picture in cytology. So crowded groups, same as in normal, in non-neoplastic endocervix, no many isolated cells, mostly sheets of cells, very crowded. And that's evident also at low magnification. Look, for example, here it's evident also in conventional smears. More is easier in liquid-based cytology. You see a number of very dark sheets of cells, hyperchromatic crowded groups, and actually in adenocarcinoma in situ, in most cases you have a quite high abnormal cellularity. And if you look at higher magnification at these sheets, if you are lucky, you are going to find that. So hyperchromatic groups of cells, very high cellularity, and look at the periphery of these sheets. You see a palissading of these nuclei with feathering. This is a key feature for the diagnosis of adenocarcinoma in situ. And at higher magnification, you see the nuclei enlarge, granular chromatin, nucleoli may be there, may not be there. When they are evident, they are mostly micronucleoli. You may find some rosettes. They are not so often found in liquid-based cytology. In real life, it's mostly a little different. You may find first these hyperchromatic crowded groups. Okay, they are abnormal, but you do not see clear and evident feathering. So maybe squamous, maybe glandular. Same here, but since you have usually a high abnormal cellularity, you have a good probability to find some sheets of cells with all the diagnostic criteria for an adenocarcinoma in situ, with palissading, with enlarged nuclei, with feathering, as you can see here, or beautiful strips, as in that case, with the evident nuclear crowding and feathering. So no problem in that case, but actually your main differential diagnosis is going to be with reactive changes in endocervical cells. And mostly in reactive changes, you have a higher cellularity, some nuclear crowding, for example, in that case. But if you look carefully, you still see some cytoplasm in the middle of this group of cells, some honeycombing, and at the periphery of the cell group, you see still very well maintained cytoplasm, no real nuclear atypicality. So that's reactive. And this case is a little more difficult because you have more nuclear crowding. It may be a little more difficult. You have some artificial, probably artifactual overlapping of these cells. Anyway, if you look at the periphery, again, you see a lot of cytoplasm, no real atypicality in the nuclei. Some of these are a little enlarged, but no real palisading, no real feathering. And what's helpful is that in this case, you usually have only one or two groups of reactive cells. You do not have the very high cellularity of adenocarcinoma in situ. Here are some other examples. That case was actually had a quite high cellularity, but look at these cells. You have a lot of cytoplasm. The nuclei are a little enlarged, but you still have a completely normal nucleocytoplasmic ratio. So clear sheets of cells with a lot of cytoplasm. Again, here you have some palisading, but it's the basis of the epithelium. And so that you see, you still have a lot of cytoplasm. And here is getting a little more difficult because you have here, you see here a clearly higher atypicality with rounded nuclei, but you still see a lot of cytoplasm. So could it be an adenocarcinoma in situ? No, because you do not have palisading, you do not have feathering, you do not have real overlapping of the nuclei, you still have a lot of cytoplasm. So the next question could be, could it be an invasive adenocarcinoma? We still have to discuss it, but I can already say no, because you have no tumor diathesis. That's the same for all cancers. You do not have isolated cells. So actually it has to be reactive. If you're not sure, you can do an HPV test. You can look for molecular or biomarkers. But we are going to discuss it later. It's you have to do it with carefully. So the next picture is it's quite typical, even if rare in this form. This is a tubal metaplasia. So tubal metaplasia is a quite common condition in uteri, but in most cases it's not sampled in cytology. And if it's sampled, you see only very few groups of cells. Without real atypicality, it really is not a problem in most cases. If you have such large group of cells and you see cilia at the periphery or maybe terminal bars, so that's going to be a tubal metaplasia. It's a benign condition, has nothing to do with HPV and with cancer, may be associated with cancer, of course, but usually then the diagnosis is going to be simple anyway. But in that case, if you have such large sheets, rarely it may occur, then look at the periphery. If you see the cilia, it's going to be negative. Probably in some of these cases, you are not going to find cilia. It may happen, particularly in conventional smear, then probably is going to be in a case with atypical glandular cells diagnosis. It may happen. So in early infiltrating adenocarcinoma, when we have that, so usually the picture is actually the same as in adenocarcinoma in situ. The features are the same. You do not have always tumor diathesis. You do not have isolated cells. And actually, the differential diagnosis between an early infiltrating adenocarcinoma and adenocarcinoma in situ may be difficult also in a number of histological specimens. So no wonder, actually, that means that if you, when you make the diagnosis of adenocarcinoma in situ, what you're actually telling the gynecologist is, I see the features of an adenocarcinoma in situ, I can't rule out an ale infiltrating adenocarcinoma, and the gynecology knows that. Early infiltrating adenocarcinoma begins to be evident when you see a higher typicality, maybe rounded nuclei, maybe macronucleoli, but most important, you see isolated tumor cells. You remember in normal epithelia, reactive epithelia, in adenocarcinoma in situ, you usually have sheets, no isolated cells or very low number of isolated cells, and of course, a tumor diathesis. When the neoplasia is obvious, then you may see that. So look here, this is a sheet of cells with all the criteria of an adenocarcinoma in situ: nuclear crowding, palisading, feathering. But here you see also evident tumor diathesis, a large number of atypical isolated cells. That's the picture of an endocervical adenocarcinoma infiltrating the cervix. In poorly differentiated cancers, it may be quite difficult in adenocarcinoma of the cervix. It may be quite difficult to recognize some features of an adenocarcinoma in situ, and then it may be difficult to make the differential diagnosis with non-cervical cancer, with extensive, large non-cervical cancers, for example, high stage, advanced stage endometrial cancer with extensive infiltration of the cervix, or maybe metastasis. This is a colon cancer, for example, with extensive infiltration of the cervix, and the differential diagnosis may be really difficult. Then you may use molecular techniques. We're going to discuss it later. And extracervical cancer usually do not show all this tumor diathesis, this evident carcinoma, these evident carcinoma features. In most cases, you have only few atypical groups of three-dimensional cells. This is quite typical on a clean background, particularly in liquid-based cytology, with often vacuolization of the cytoplasm, nucleoli, and abnormal chromatin distribution. So a typical group of cells, even more evident in metastasis from extrauterine tumors, for example, that case in ovarian cancer, serous, high-grade serous cancer with metastasis in the cervix, and you see three-dimensional groups of highly atypical cells with very evident nucleoli on a typically a clean background. So, and that's okay. Again, that's all. So we have a glandular pattern. You look in the slide, you look at your screen, and you see abnormal glandular cells. If you see three-dimensional clusters, a three-dimensional architecture of small cells, so it's actually think about endometrial cancer, or think about metastasis or extracervical cancer. If you have two-dimensional sheet of differentiated columnar cells, you still see a lot of cytoplasm, no feathering, no nuclear palisade, no hyperchromasia, probably is going to be reactive. If you see feathering, nuclear palisade, you see hyperchromasia, no tumor diathesis, no isolated cells, it's going to be an adenocarcinoma in situ. If you see the features of an adenocarcinoma in situ and isolated tumor cells, tumor diathesis is going to be endocervical cancer, invasive. And if you see only a poorly differentiated cancer, it's going to be an adenocarcinoma, not otherwise specified. And maybe you are going to need, or you can perform, if you want, also some additional tests. So one typical differential diagnosis is Heisel with pseudoglandular pattern. It happens particularly when you have a involvement of the endocervical glands, from the Heisel with involvement of the endocervical glands, and these may mimic adenocarcinoma in situ. In some cases, you see hyperchromatic crowded growth, but conversely, the differentiation from an adenocarcinoma in situ should be relatively simple, because your margins are quite sharp. You do not see feathering, you do not see nuclear polysemia at the periphery of the sheet. So it's may helpful in the differential diagnosis, but actually the differential diagnosis between glandular lesions and in situ glandular lesions and Heisel is actually a question of the first 5 seconds. If you look in the smear at even at low magnification, and you already see large groups of cells, hyperchromatic cells with some feathering, and you think, oh, it's going to be an adenocarcinoma in situ, usually you are right. And if you think, oh, it could be an adenocarcinoma in situ, could also be a squamous lesion, in my experience, usually it's going to be a squamous lesion. Of course, it's not a 100% rule, but it may help. And anyway, never forget that in many cases, about 50% of adenocarcinoma in situ, you may also have a coexistent a high-grade lesion. Usually, so a Heisel, look at this atypicality of this nuclei. So adenocarcinoma in situ and Heisel are often found together. So in some cases, the differential diagnosis between reactive and particularly adenocarcinoma in situ may be quite difficult. And usually in these cases, you have you see only one criterion for atypical for adenocarcinoma in situ. And for example, you see some nuclear crowding, as you can see here, but at the same time, you see at the periphery of the sheath, you see cells with a lot of cytoplasm, and maybe it's only the one group of cells that you have in your smear. Or here, for example, you see a group of cells with evident atypicality. In that case, the nuclei are enlarged. You have a relative lack of cytoplasm, so quite a crowding, nuclear crowding, but it's maybe again only one group in all your sample. Actually, this is negative. This is an adenocarcinoma in situ, but in that case, it may be really difficult. You may prefer to call it atypical glandular cells. Depending on the atypicality, you may call it favonoplastic or not. In that case, of course, you can do HPV test and even better genotyping. And genotyping is may be very useful because most or adenocarcinomas and most adenocarcinoma in situ particularly are going to be positive for HPV 16 or 18 or 45 or a combination of this HPV. And actually, if you have, for example, an ACC and typical glandular cells case with this combination, with these HPV genotypes, then you have a quite high risk of adenocarcinoma in situ or invasive adenocarcinoma. So it can be very useful, but as well as biomarkers, for example, P16, Ki67, work very well with glandular lesions. But what's important to remember that not all adenocarcinomas, not all cancers in the cervix are actually HPV positive. For example, if you look at atypical glandular cell cases in women that are 50 years and older, so that even if you have an HPV negative result, you have a high percentage of extracervical malignancy. So some of these cases are going to be extracervical cancers, and they are HPV negative. So it's really important that you carefully look at the morphology. And only when you're sure that your differential diagnosis with an adenocarcinoma in situ, then you can perform molecular biology, HPV testing, typing, extended genotyping, P16, Ki67, but you have to be sure, carefully rule out all what is extracervical. And even if you look at cervical cancer. Look here, for example, in adenocarcinoma in situ, most of these, almost 94% are HPV positive. If you look at invasive adenocarcinoma, depending on the study, between 10 and 25%, depending on the country, maybe even if they are primary adenocarcinomas of the cervix, they may be HPV negative. So the issue is that these cancers are, in the old terminology, they were called also adenoma malignum. They are mucinous cancer. And they show often a very high differentiation. So they may be difficult to recognize even in small biopsy specimens. In cytology, usually in our experience, it's not so difficult because you have a higher number of cells and not only a small biopsy specimen. And somewhere you are going to find clearly atypical nuclei and particularly nucleoli. This is an example of mucinous adenocarcinoma of so-called gastric type. And you see that somewhere you are going to find some real high atypicality. And this is quite evident and quite typical in this nuclei. Look at these nucleoli and how these nuclei are enlarged. And besides this, you have a very high number of nucleoli. Look at this epithelia here. The atypicality is not so high, but you have a very large number of small nucleoli, micronucleoli. Almost all the nuclei show a micronucleoli. Nuclear overlapping is less often found. And besides this, since these are mostly invasive cancers, not adenocarcinoma in situ, then in most cases you are going to see also an evident tumor diathesis. So cytologically, the diagnosis is quite possible. So that was actually that's all actually. You see, we have worked with pattern. We begin with pattern. The classification comes at the end. And you look at your slide, a glass slide, you look at your screen and you find these abnormal cells. You decide first whether they belong to the large cell pattern, small cell pattern, or glandular pattern. Actually, this is important also because the criteria, cytologic criteria, the main cytologic criteria are different for these patterns. For example, if you have a large cell pattern, so the main criteria is going to be the nuclear enlargement, so the nuclear cytoplasmic ratio. That's typical for a leucil. Of course, you're going to look for tumor diathesis, hyperchromasia, nucleolar chromatin, and so on. But the first criteria that you're going to use as the nuclear enlargement. In the small cell pattern, you have again the nuclear cytoplasmic ratio, of course, but you have also a typical nuclear membrane with grooves, indentations, the anisokaryosis, which is quite evident in high-grade lesions. And in glandular patterns, you're going, of course, to look at tumor diathesis, nuclear cytoplasmic ratio, and three-dimensional versus two-dimensional, but you're going to look primarily, particularly in adenocarcinoma in situ, at the architecture. Is a key for the diagnosis of glandular lesions. So different patterns, different same criteria, but some criteria are more important depending on the pattern. And actually, this working with pattern is nothing new, of course, but now is more fashionable than before, because if you look what artificial intelligence is doing, in most cases, depending on the system, but in most cases that I know, at least, the artificial intelligence is showing you a gallery of images, and these galleries distinguish between large cell pattern, small cell pattern, and glandular pattern. So you see, if artificial intelligence can do it, we can do it too. So thank you very much for your attention, and that was for my webinar.